Hi, I'm going to talk a bit about what we see issues in the GI tract in Loeys-Dietz, and as well talk a bit about nutrition. So first of all, sort of our learning objectives is hopefully you'll be able to go home and understand the role of the issues in the GI tract as well as the role of nutrition. And if you ask me, we probably should start every one of these sessions talking about nutrition, because no matter what's wrong with you, if you have good nutrition and you're not malnourished, which we can look at in many ways, it's going to help every other system in the body. So first, what I'm going to focus on is the eosinophilic GI disease that's seen in Loeys-Dietz syndrome. We see this, though, in many other syndromes, and we see it in many patients who we don't necessarily have an additional diagnosis. So a lot of the advice that we give patients with Loeys-Dietz is based on the experience of managing other patients who have eosinophilic esophagitis or eosinophilic GI disease, which by far the most common area that's involved is the esophagus. So 20 years ago, we really didn't see this disorder. So there has been an unbelievable increase in the incidence of eosinophilic esophagitis within the general population over the last 20 years. And it sort of parallels the increase of what we've seen in allergy and in asthma as well. So my one rule of thumb is that you can see eosinophilic esophagitis with any other problem because it is so prevalent in the population, just like we can see asthma in any other, associated with any other problem, whether it is independent of your second problem or possibly, like in Loeys-Dietz, maybe related to the gene problems that are leading to the bone abnormalities or the vascular abnormalities, also leading to problems with how you regulate or how you manage inflammation in the GI tract. But may also go back to some very basic things on how do we even, when we're born, we're sort of this sterile GI tract, and then how do we allow our bodies to accommodate putting food in, which was absolutely foreign, and tolerating it and using it as nutrition and using it as a pleasure source and part of our social life, and not get sick. So now we say that in the population, you can see eosinophilic esophagitis anywhere between 1 in 1,000 to 1 in 10,000 people. So this has really changed. But if we look at people with connective tissue disorders, this is based on some recent work out of Cincinnati that has a very large eosinophilic clinic, that actually there appears to be an 8-fold increase across the board in looking at patients or looking at people who in addition have some type of connective tissue disorder. And we know that based from the work in Baltimore, that if you're looking at specifically the LDS population, about 30% in their clinic group had eosinophilic GI disease. So what your symptoms are depends on what is your age of presentation. So early on, when we see infants and toddlers who have eosinophilic esophagitis, they will often present with feeding difficulties. They will have trouble transitioning onto solid foods. You may have a lot of vomiting and what has classically been called acid reflux, which is really not acid reflux. It's protein intolerance that's driving vomiting when they're babies and leading to inadequate calorie intake, leading to feeding behavioral issues. So we'll see children that even when we start to treat them, that they still have a lot of behavior related to their feeding, and I'm sure there's families here that have gone through that. As you get older, then you may present more with stomach aches and vomiting, but really as you start to get to school age, and if you ask the right questions, even in some of the preschoolers, you'll start to get the complaint of solid food sticking on the way down. So what I ask are, are they very slow eaters? Do they need to drink a lot with all the meals? Sometimes does it feel like the food just doesn't go down when you're eating chicken or something? So, and if you get a yes to those questions, then you need to start thinking that there may be something wrong in the esophagus, and look there. I think the advantage of having a diagnosis early now of LDS is that if I was sent a child who in their transition from being on milk or formula and going into solid food who's having a lot of trouble with transitioning, we'd have a much lower threshold for actually looking for eosinophilic esophagitis without saying this is like all the other kids who won't eat broccoli. So you're going to actually look and see if this is a problem, because we actually have intervention that will be helpful. So how do you diagnose this? Well, first you have to have a low threshold to investigate. If you look at blood work, sometimes you see a rise in the eosinophils, which are really, they're white blood cells that have red granules in them. So they're called eosinophils, because eos is red in Greek. And they're the same blood cells that get raised if you eat strawberries and are allergic and are going to get hives, or you go to South America and you pick up a parasite. So they will be increased. And sometimes when you just do a blood test, you can see it in the blood count, but not always. Usually we will see actually a normal hemoglobin and a normal serum albumin, or a measure of the protein. So those aren't clues. You can even do an immune globulin IgE, which we would think would be elevated, but it doesn't always have to be. Now, if for example, you have eosinophilic esophagitis and you have a raised eosinophil blood count, then it is nice because it's something that we can follow, or get a clue when maybe your symptoms change, that maybe that's part of the problem again. And in other patients, we can't. Looking at RAS testing, which is the blood test to look at which foods you're allergic to, is not necessarily very helpful. And at least in Ontario, is not covered by OHIP, so you need to pay for it. And the problem is that not all the foods that people remove from the diet in eosinophilic esophagitis are you going to react to with hives. Are you going to show positive on skin testing or patch testing? In fact, many of the foods, really we don't have a test that says, yes, it needs to be dairy and wheat, because the tests aren't sensitive enough yet. We go back to our immunology and allergy colleagues, and they're working on it, but we don't really have a good test yet. And when you do, even though you find food sticking on the way down, we can do a barium swallow, which looks at how things move down the esophagus, and it can actually be perfectly normal. So it doesn't have to be abnormal for me to look down in a patient and actually find that the esophagus is a bit stiff, or have an explanation for why the food is sticking. So if you've gone for any of these tests, if you have eosinophilic esophagitis, this is what we see. So the first picture here is the barium swallow. Now this is a patient who actually has an abnormal barium swallow. So it looks a bit normal and a bit stiff. So it makes sense why the food would stick. But many patients will have a normal swallow. If you look down, if you have an endoscopy, which is how we make the diagnosis, what you see, these are classic findings that you see, so that you can see these lines. 2 lines are called tram tracking, because they look like the rail lines for the streetcars or the trams. And you'll also see these sort of white plaques, which actually, when you look under the microscope, are actually all those eosinophils that have come up to the surface of the esophagus. And sometimes you look down and it looks like it should be the airway, but actually we're not in the wrong spot. But this happens again in the esophagus. And if you look under the microscope, this is what you want your esophagus to look like, because this is a nice, normal, healthy esophagus. And this esophagus is somebody who has eosinophilic esophagitis, and all these little red blotches in there are actually all the eosinophils in the esophagus. And they make the esophagus stiff, and they increase the amount of fibers running deep below the surface in the esophagus. What we know is that when we actually treat this disorder, you can make the esophagus come back and look like this, look like normal. And you can actually reverse the amount of fibers running deep in the esophagus, at least in the classic people that have eosinophilic esophagitis. So that sense of food sticking will go away. And in fact, even when we have so much fibrosis that we get a stricture, or what we would say like a scar, a fixed narrowing, many times just with treatment, we can make that go away. We don't necessarily have to go in and stretch it or anything else. The treatment will make it go away. So there's a lot of reversibility with treatment. And this is for the healthcare people in the audience. There actually are guidelines on, how to investigate this. And since our time is limited, I'm just going to leave this as a resource. This was put together by our European pediatric GI colleagues on what to do and how to investigate this disorder. So how do we treat it? Because we want to know that you have it, because we can actually do something about it. And there's really two big areas of treatment. One area, probably the original one I'll talk about first, is drug therapy. Well, the very, very first treatment was actually just going in and stretching the narrow area. And it works very well because the food doesn't stick, but it doesn't actually get rid of the inflammation that's in the esophagus itself. So then people looked at, well, okay, so how do we get rid of inflammation? Well, commonly, if you have a lot of inflammation, we use steroids. So we can actually use topical steroids. We don't necessarily have to give you a pill that all of your body gets exposed to the steroids. We can try something that's just really in the esophagus. So the first thing people tried are the same kind of topical steroids you use for your asthma. And we tell you to swallow them. And to be honest, even when you're using your inhalers, you swallow a fair bit of your medication in your inhaler. And it works very nicely for making all that inflammation go away. So we still use those. Occasionally we have to put somebody on a systemic or a pill to improve their esophagus, but the topical steroids work very well. And we use both, telling you to take an inhaler and swallow it, or we can take the steroid that's in the inhaler and we can mix it in something and make a little slurry that you drink. So when you have very young patients, the inhaler is very hard for them to figure out how to use, but we can actually have them swallow the slurry and it will coat the esophagus and makes the inflammation go away. So once you get the inflammation away, then how do you keep it away? And that we're less clear. You would think if this is a relatively new disease, we would have been really good at having all these trials of treatment and how do we keep you in remission, but we haven't. But we, again, look at some of the medications that people have used in asthma, particularly in kind of allergic asthma, and have looked at using these to try to keep people in remission. And definitely the next group here, monoleuc class or singular, I've had experience using in patients where we've got them better on the topical steroids or on prednisone, and then we've used this to try to keep them well. Ketotifen is a medication available in Canada. It's not available in the States, and it actually works very nicely if you happen to have eosinophils in the colon or for eosinophilic colitis, not so much for the esophagus. And then lastly, we know that proton pump inhibitors, an old-fashioned acid-blocking medication, which wasn't very effective early on in children with EOE, has been very good in managing adults with EOE. So we keep kind of rethinking how we classify it, and all these other people that have EOE are going to actually lend to knowing how to treat people with Loeys-Dietz who have EOE. Diet therapy, again, is also another alternative, and this really came out of the pediatric experience, putting patients on very elemental diets, drinking elemental formula, or putting them in a tube, making everything go away, and then trying to figure out are there some triggers driving it. And right now, again, unless you have positive skin prick testing, we're not so good at figuring out specifically, except through trial and error, what the other foods are that are driving it. The most common ones appear to be dairy, wheat, eggs, legumes, peanuts, and other legumes, soy, which would fall in the legumes, and tree nuts.
Attention please. There will be bell testing being done on the second floor, Zone 4 Annex building. Please ignore all bells and alarms. There will be bell testing being done on the second floor, Zone 4 Annex building. Please ignore all alarms and bells. There will be bell testing being done on the second floor, Zone 4 Annex building. Please ignore all bells and alarms.
So over the years, people have looked at how can I do this dietary intervention in a way that actually families can do it and whoever is the person who's on the diet can live with it. Because to say you're going to drink some or get a G-tube and have elemental formula for the rest of your life is really not practical and has a huge effect on your quality of life. So originally we started taking away the 6 most common foods, which would be dairy, soy, wheat, tree nuts, eggs, and fish, and then adding them back because most people don't have a problem with all of them. Then people looked at, well, what's more common in one group and the other, and then they discovered in adults that also doing dietary treatment also can make adults better. So looking at the group kind of depends on looking at the study. So probably the 3 biggest offenders in the end are dairy, wheat, and eggs. And there's some nice studies. What's nice about having the adult studies is that at the end of every abstract, the adults will tell you how hard it is to stay on the diet. Because it's not like eating peanuts, where you're going to eat peanuts and you're going to feel awful and have an anaphylactic attack. You're going to end up eating dairy or eating wheat, and over time you're going to get your food sticking back again, but just not an immediate, eat it and get sick. So it's hard to stay on the diet. And when you're a teenager, you still want to eat the pizza with your friends on the way home. So the management with diet is difficult. In my practice, I've found that there are patients, if they're really having a lot of trouble, we've treated them with medical therapy, and then we've met and had a discussion about how to go forward with dietary therapy. Because if you have a teenager, they have to buy in, because you cannot serve them dairy at home, but they can go have pizza with their friends every day, and so basically they're not on their diet restriction. We know that aeroalleragen involvement is important, and there's definitely people with classic EOE that have seasonal symptoms. And I have kids who will tell you that April and October are terrible. So we have to plan what we're going to do because it's driven by the aeroantigens. So it's important. And whether things like going back and people are starting to give allergy shots and things again, whether that's going to change some of it, we don't know. But that's possible. And then this is really the issue of diet and quality of life, because we don't really know how to necessarily pick out specifically all the foods, except we can tell you the foods that you are truly allergic to, but not necessarily intolerant to. And there is an issue of rebound anaphylaxis. So what we've discovered is that when we've now put some patients with eosinophilic esophagitis on an elemental formula to really heal up the esophagus, when we start adding back in foods, I've had a patient, definitely other centers have had a patient or two, when you add back a food that they were tolerant to before, they actually develop anaphylaxis. It tends to be more in people that already have a long list of true food allergies, but we need to be careful because we've already really restricted those patients in their food choices. And so we're going to flip to nutrition, but nutrition should be part of everything. Patients with Loeys-Dietz can be underweight or they can be overweight. So we've seen everything. But all of this is mal or bad nutrition. So it's important that wherever you're being followed, that your nutrition be looked at and that you really actually get involved with a clinical dietitian. In young children and infants, we need to remember they can have eosinophilic disease. We need to remind the cardiologists that their medications often have significant bad effects on how the GI tract moves and functions. So not that we can stop their cardiac medications, but we kind of need to maybe plan ahead sometimes. We have people who are fasting and recovering from surgery. They have their diet restrictions already related to their allergic disease. There's an expense to all the really hypoallergenic formulas. If any of you have had to pay out of pocket, you know about that. And then there's the development of feeding behavior issues in the young patient who's felt unwell when they've been fed, and now we're trying to get over the resistance. And we've had some patients, and other people have had this experience, that when you start to give a long list of foods that you cannot eat, and we say they're going to make you sick, we almost create an eating disorder in patients because they become afraid to try to eat anything. You are what you eat, so hyperallergenic diets may not be nutritionally complete, so you need to do it with a dietitian. Gluten-free, which I know is very in vogue at the moment. For most people, it actually adds weight. You don't lose weight, but the weight that you add, even though we have lots of patients who want to add weight, is not good weight. We actually have a higher glycemic index on a processed gluten-free diet. So remember, there's lots of gluten-free food that's out there naturally, which is the little heart. So the heart health foods are great, but if you're going to replace your traditional bread with gluten-free bread that you buy at the store, or crackers and cookies, their glycemic index is much higher. So they're really not heart healthy foods. And the best advice, I think, is to review with a dietitian, that we need early intervention, so you really need to early on monitor growth, make sure we're happy. I think we're not clear how we should be looking because of the body habitus. Like, what should we be doing? Should we be pushing to have more lean body mass? How do we follow that? What do we do and change in the diet? And would that make patients better? And there's some new tools coming up. And do we need to look at whether caloric needs are actually increased, and again, how we're providing them? Constipation is common, can be related to malnutrition. Eosinophilic disease doesn't have to give you diarrhea, often gives you constipation, so that change, taking away the food you're intolerant to, can make your constipation better. And then the support systems in the GI tract are also weak, which leads to dilatation and your colon not moving very well. And treatment is really, again, looking at your diet, looking at things that help the colon move. So I think one thing that there's lots of use currently is any of the PEG 3350 products, because they're easy to use, they work well, there's some nice studies, but sometimes you need to add other laxatives. And again, with your healthcare provider or your gastroenterologist, if you're seeing one, may be very helpful. So really, from the beginning, you need to ensure good growth velocity and adequate, well-balanced diet. Eosinophilic disease is common, so you need a low threshold to look for it, beginning with the projectile vomiting baby who may actually not be tolerating dairy. And both diarrhea and constipation can occur as part of eosinophilic GI disease. And although inflammatory bowel disease has been reported, I haven't seen it here. And the question is, what's the mechanism, and is that moving from eosinophilic disease with more fibrosis that's not reversible, becoming more like classic inflammatory bowel disease, which is different than what we've seen with the general population's eosinophilic disease. Okay.